So prevention tends to take a back seat to the immediate problem that patients face. Because of that, there are large gaps between what we know we can do in prevention and what actually happens in practice. So people have thought about a lot of means to try and improve that evidence-practice gap, one of which is financial incentives, but it's only one of a number of means. First criteria is, does this thing that you want to incentivise actually do good? The other criteria are, is it a long-lasting problem? It's not going away by itself. Is an incentive the best way to do that? One is the what's called the opportunity cost by economists. To put that in a clinical context, patient comes in, there might be, in addition to dealing with their current clinical problem, 10 preventive things that you might think about. Smoking, blood pressure, cholesterol, exercise, immunisations, etc. If you introduce a financial incentive for one of those, the patient and the doctor will then tend to ignore the other 9. So what you incentivise changes what the behaviour is. That's why you're doing it. But you've got to think, okay, but what am I then not going to be doing as a result of the incentive? Another is the loss of motivation that happens. So if you incentivise people, you actually change their what's called the locus of control. They no longer feel like they're in charge of things, that somebody external is dictating what to do. And it's demotivating. That's particularly been proven in education, where kids are less motivated to do work if they're given incentives. You'll get them to do the immediate thing, but actually they lose that internal drive. And clinicians have the same thing, that they lose the internal drive to do things, and they start to become focused on the external incentive. And so this has been shown, at least with nurses within the UK system, where there was a big financial incentive. A couple of ways of doing that is just public health promotion programs. You raise people's awareness of this so they bring the issue to their doctor, such as needs for immunisation or smoking cessation, heart attack prevention, etc. Another way would be to restructure their records. You could do this with a patient-held record where you have the preventive items in it. We do that with childhood care in particular, where young infants get a structured record and you go through the preventive things. The parents know about it, so the clinician does it. And again, if they've got that checklist in front of them, they tend to do the things. There are sort of reminder systems, effectively. It's a way of structuring the reminders to do these things. It's not the immediate problem that the patient has come in with, so prevention tends to take a back seat, and you need a reminder to do the correct prevention. And building those reminders into the system is a very good way to get clinicians to do what they know they should do, but they tend to forget it. So I'd see an incentive as sort of being the last ditch. When everything else fails, think of a financial incentive.
So we know that paying for prevention, that is paying additional amounts for prevention, will increase the use of preventive care measures. There are a number of caveats to that, but in general, that is an effective strategy. In terms of its effect on health, I think we rely on the existing evidence for these preventive care strategies that suggest they improve health. That's why we target these, because they're evidence-based measures in the first place. We pay doctors for everything they do, generally speaking, and we pay them in ways that encourage the use of high-tech interventions, usually sort of the other end of the spectrum from preventive care, and for a variety of reasons, we underpay, relatively speaking, for prevention. And so newer policies aimed at encouraging prevention through financial incentives are trying to change the balance of the way the incentives work today. Well, there have been lots of efforts recently to use systems to increase the use of preventive care, so systems that track patients, registries, remind both patients and physicians when they're due for recommended screening, recommended testing for chronic disease, integrated systems where they really do control and use group norms to encourage certain kinds of treatment behavior. They are much more effective than using financial incentives between unrelated entities like we do in the rest of the marketplace. So financial incentives have a lot of problems with them. We cause a lot of harm with them. And unfortunately, because we have private insurers and we have small independent providers, that's sort of the only mechanism we have. We can't sort of sit everybody down with the data and the experts and convince them that it's the right thing to do. In general, the evidence to suggest providing financial incentives to increase preventive care will save money is thin at best. And in general, health economists do not believe that increasing preventive care will save money. It's true in a few cases, but overall, prevention improves health outcomes, but it costs money. Many health economists are out there saying, please stop saying that the reason to do this is to save money. We should do prevention because it's the right thing to do. We want health, but it's not going to save money, and it's not the right measuring stick.